Good morning, everybody. Welcome to this part of the presentation of the morning's agenda. As was described, I'm Michael Dodds. I work at the Wrigley Company, so I've got to provide a conflict of interest statement, so that anything I say as a scientist for the Wrigley Company may be influenced by the fact I work for the Wrigley Company, but I'm here to convince you, I hope, to show you that sugar-free chewing gum, a little bit closer, I'm sorry, sugar-free chewing gum has some real preventive health benefits, and I'm going to talk a little bit about maybe some new concepts. It's fairly old news, I think, to many of us that sugar-free gum promotes remineralization, maybe reduces caries, but I'd like to present some new material today that I think is really more in line with current thinking of the role of the oral ecology and the caries process. So what I plan to cover today is about half a dozen topics here. I'd like to look at the global burden of dental caries, thinking about a little bit about caries and eating patterns. Are there changes? I think that we're beginning to recognize now that there are changes in the way people eat through snacking behaviors, and those have been reflected by changes in the World Health Organization sugar restrictions. I'd like to talk a little bit about some new thinking on oral ecology, the terms homeostasis, allostasis, and resilience, and how saliva can influence those. And of course, I would like to talk a little bit about how sugar-free chewing gum can influence saliva itself and therefore drive this idea of oral homeostasis. Finally, touching on some specific polyol effects with respect to xylitol and another polyol sugar called erythritol. So, very first thing I'd like to cover off is what's going on with dental caries. Many of us, well, actually, I'm looking at the audience, many of you are much younger than me. When I trained, we were taught that caries was on the decline, and there was probably been a 50 or 60-year decline in the overall global prevalence of caries. And of course, this is due to fluoridation, due to increased knowledge of the process itself, and fluoridated toothpaste, these sorts of things. However, a little bit more recently, there's been some concern that maybe understanding, of course, that caries is not evenly distributed across populations, but maybe there's an increase in the prevalence of caries itself. And some of this came from some data from the Haynes studies in the United States that suggested that there was an increase in caries experience in even children as young as the 2 to 4 year age group. So untreated caries increased as well in children 6 to 8. And of course, there were disparities in the prevalence based on different need states. So this has been termed a pending public health crisis. So let's go a little bit into maybe some of the reasoning behind what this increase in caries, or maybe perceived increase in caries, has been attributed to. So here are the data from the CDC, and as you can see over here, this is the increase from 1988 to 1994 versus 1999 to 2004. The overall experience of caries increased from 18 to 24% in these young children, 2 to 4. So obviously, they did not meet the Healthy People 2010 target that was set at that time, and there was obviously a lot of concern that was what's going on here. Why are we seeing an increase in caries experience and prevalence in these children as young as 2 to 4? This is also some data that was published from Professor Diyu Hu in Chengdu from the NCOH in China, so I don't have anything much more recent than this, and I don't have the data, I'm afraid, specific prevalence data on Taiwan, but you can also see here that in general terms, over this 10-year period from 1995 until 2005, there's been trending a decrease in the prevalence of caries. Of course, we think that's good, so in 5-year-old children down from 77% with a DMFT of 4.48 down to 3.5 and 66% prevalence. However, a slightly alarming trend here, looking at the older population, which shows an increased prevalence of 75% and an increase in the DMFT from 2.49 to 3.8. So maybe this is a reflection of older people keeping more teeth longer and showing disease, but certainly there is a trend of potentially an increase in caries, and I understand that Taiwan has high caries prevalence itself as a country. So what some of this has done has led to guidance from the World Health Organization. So the study on the top from Paula Moynihan and Kelly has really defined the WHO guidelines that came out and suggested that caries should be reduced by reducing sugars intake. And of course, this is aligned to other programs, issues such as obesity, but certainly the World Health recommendations come through as strong recommendations to decrease intake of free sugars throughout the life, and also to reduce that intake of free sugars to less than 10% of the total energy intake, with a strong recommendation, and also a conditional recommendation that consider a reduction of less than 5% of total energy intake. So what does this mean when we start to think about eating behaviors and eating patterns? Caries itself, I think many of you recognize that this is a very, very static definition of a pathological process. And this was defined by the World Health Organization probably, I think, about 1962. This really defines a disease that's not the dynamic process that we understand in this day and age of caries, which is more reflective here from thinking about organizations such as the Canberra organization, where they really understand that this is a much more dynamic process, influenced by periods of demineralization and remineralization, of course, influenced by the saliva, influenced by other factors. And those factors include factors inside the mouth, so extraoral and intraoral. Within the mouth, the intraoral factors we could consider here would be the biofilm itself, would be the plaque pH, would be the salivary flow rate and its composition, particularly its buffering and its composition with respect to its supersaturation, the content of calcium and phosphate that help maintain the enamel mineral health. Environmentally, so the external influences we'll talk a little bit about as well. The diet and frequency of eating would be probably the two that I would focus on here, but of course oral hygiene and fluoride are very important components of that. So we can influence some of these factors, as I'll be describing, I hope convincing you of, through stimulating saliva. So, of course, this is the standard dogma of how diet itself acts to impact oral health. Intake of fermentable carbohydrates, fermentation by microorganisms in the dental plaque biofilm, resulting in acid generation, a spectrum of different acids, the net result being a decrease in the pH of the dental plaque, resulting in demineralization. So, of course, with that context, the more you eat, the more the chances of demineralization increase. So if we look at these two panels, these are some representations of what would be on the top panel here, on the top panel representing a typical, what I would say is old-fashioned traditional eating pattern of 3 meals per day. And this represents the plaque pH over the 24-hour period when you have a lunch, and I apologize, this is obviously a very typical Western European sort of meal pattern, a breakfast consisting of cereal, milk, and orange juice, a lunch, and a dinner, all of which could potentially drop the plaque pH below a critical level, at which point enamel demineralization could occur. On the bottom is maybe a more realistic assessment of what the kind of thing that's happening now. In today's society, we're fast-moving. We eat on the go. We snack. Kids are consuming energy drinks. Sitting down and eating a meal with your parents 3 times a day is probably becoming more the exception than the norm. So what we're seeing as a result of that is increased number of periods where the plaque pH has dropped below 5.7 or whatever critical point you accept as being the point at which demineralization can start to occur. So this could be potentially a tipping point just through changes in dietary snacking behaviors and exposure to, more frequent exposure to sugars during the course of a typical day. So I have some data. This was from a European health report that came out in 2010 that suggested we're actually consuming, Europeans at least, were consuming snacks and other things on average 5 times a day. 5 times snacks a day. So out the window goes your 3 times a day assumption. And as many as 48% represented here are eating 5 or more times a day. 18% eating 18% eating 5 times a day, 30% eating 4 times a day. 5 times a day and 6 times a day. So really, half of the population is eating more than 5 times a day. What does this mean? So traditionally, the potential of a food substance to cause caries has been assessed through plaque pH measurement, and this work goes back decades. And the Tooth Friendly International Organization, this is at SEAL here, based in Zurich, has provided some guidelines on foods that are safe for teeth, and those guidelines are based on intraoral measurement of plaque pH using a telemetric measuring device that if the pH of the dental plaque does not drop below 5.7 during or immediately after consumption of the food, then it could be labeled as being safe for teeth or tooth friendly. And the bottom panel here represents an example of a lozenge that was consumed. At this point, this hatch line represents consumption of the lozenge. This is the pH of 7, around about 7, at the beginning, and then after consuming and during consuming the lozenge, there is minimal effect on the plaque pH, and I'm afraid my pointer seems to have died on me. But at this time point, the second period of this pH curve shows that there is a decrease in the plaque pH when a traditional sugar-sweetened lozenge is consumed. So on this basis, the first lozenge would be labeled safe for teeth, the other one not for safe for teeth. This provides some reassurance about carcinogenicity or non-carcinogenicity of foods when consumed in isolation at one point in time. But at the same time, we don't really know what the overall holistic impact of these more frequent eating behaviors are on things that could influence the oral ecology as a whole. Excuse me while we get a new pointer set up here. Thank you. Okay, thank you. So based on research that was done decades ago, this was work from people like Basil Bibby and Edgar. Categorized foods and drinks and were categorized as being either less or more acidogenic based on a number of plaque pH studies of this ilk. So these would be categorized in terms of the types of foods, fruits, nuts, starch-based foods, soft sweets, hard sweets, soft drinks. And if you look here, then you can see that these sweets, both soft and hard, would be considered the most acidogenic of those. And then over here, let's say peanuts would be non-acidogenic. What is surprising, though, is actually some of these foods that you wouldn't have thought of, dates and raisins, certain kinds of breads and cookies and starches, even breakfast cereal, may be moderately acidogenic. So in that context of frequent consumption, some of these foods may act to change the balance of the ecology of the mouth, the makeup of the microbial biofilm itself. So to sort of bring that together, more frequent exposure to sugar is going to be more time that the teeth are at risk with when the pH has dropped below the critical pH. As such, it will tend to favor more demineralization. So the balance between demineralization and remineralization has been shifted in favor of demineralization, of course. But I think what's maybe more interesting is this concept of a shift in the oral ecology. This could be selecting for a more carcinogenic biofilm. So it's not just the one-off reading of plaque pH that you should be concerned about. It's the more frequent exposure and the more frequent number of times during the day that the pH is going down. It could be affecting the makeup of bacteria in the dental plaque itself, and in some cases may actually raise the carcinogenicity of carbohydrates not traditionally considered to be carcinogenic, such as starches. So I'm going to talk a little bit about oral ecology and sort of put together a bit of a hypothesis on that, which is, as stated here, frequent exposure of the oral cavity to sugar and low plaque pH levels may cause a shift in the ecology of the biofilm in favor of more acidogenic or potentially carcinogenic flora. And a lot of this work goes to the plaque ecological hypothesis of Phil Marsh, and I'll be referencing some of that material. And of course, this shift is subtle. You probably don't necessarily see it in just one-time plaque pH testing, so we have to think about the totality of exposure of the oral cavity to the food and the diet in terms of the net result of that. So I'll talk a little bit more about oral ecology. I'll think about how this can be applied using terms such as homeostasis and the ability of the organism to maintain a healthy state. Another term I'll bring up and just define, I think, is allostasis. And lastly, we'll think about resilience. And this work itself is really predicated upon the shift, our understanding of the shift in the caries disease process. And of course, going back a number of years, we know the classic Venn diagram interaction that results in caries, the interaction of the dental plaque bacteria with the tooth surface and the diet, the carcinogenic diet over time will result in caries. And that really is the basis of that is I would say, the non-specific plaque hypothesis. But really there's been a shift, I think, in our understanding of that process. And it's not really just the bacteria, it's not just the plaque, it's not just strep mutans, it's the overall balance of key microorganisms that can influence the process, an environmental trigger, and a susceptible host. So again, from Marsh's work, we understand that the oral microbial ecology can be influenced by these external factors. The saliva, the flow, the maintenance of a healthy saliva flow is very important. Its composition, its ability to neutralize acids, of course, is huge. Lifestyle, and that would be dietary choices, of course. The microflora itself, the overall oral microbiome, and some of the defenses. So we would consider oral disease is not the norm. A healthy oral cavity should be the norm, and it's maintained by homeostatic mechanisms. And again, this is from Phil Marsh. So in the condition of health, the dental plaque is a stable community, and it will be the usual condition is health and is not disease. But only when you apply some sort of external pressure, and it's termed an ecological perturbation on that process, does the ability of the community itself, it's not able to prevent the disease progression. So that if you get frequent sugar or low pH conditions, or in an alternative consideration, low saliva flow, then you may get caries. You may get a change in the balance of bacteria, more acidogenic, aciduric bacteria and dental plaque, conditions predisposing to a greater proportion of strep mutans and other carcinogenic bacteria. So homeostasis, I believe, is a key concept to this process. And if we were asked, what is the definition of oral health, I think most of us would start to come back with, well, it means you don't have caries, you don't have gingivitis, periodontitis, active cavities or any other pathology. But we think in general terms, and this is some work that has been led by a consortium, a European-based consortium, has been out of the Netherlands, called TIFN, TIF Food and Nutrition, created some proposals here that suggest that biological processes promote control over homeostatic balance of oral health. And this could be based on the microbial activity, interactions between bacteria in the mouth, the host and microbiota interactions, adaptations, could be biochemical or immunological, and ultimately we can somehow sustain oral health by helping those processes. So here's at the bottom here, I'll go through this a little bit more later, is a representation with the green being the healthy homeostatic, and these changes are just disruptions going into conditions that allow you to return to baseline, as it were. As pediatric dentists, I'm sure you all know, you don't see the same patient twice. People change, children change immensely in those few years from birth to 16 and 18. So there is a term has been applied, and this was from a recent review by Agir Zaura and Bob Tenkati, that they use the term allostasis. Allostasis means that the condition changes. So let's use an example, puberty. Changes occur at puberty. There's changes due to tooth eruption. So things don't necessarily return to the same place, but in general terms, there is a resilience of the oral cavity to external pressure. So environmental pressures are represented here. They could be environmental, behavioral, and these springs represent that resilience, the ability of the organism, the oral cavity in this case, to respond to external stresses. There's a certain amount of resilience built in, an ability to adapt. So resilience seems to be a key word here, and this is being proposed by this group from the Netherlands. This is the capacity of an ecosystem to respond to perturbations. I'm sorry, is this okay? Apologies, and we're getting a little bit of feedback here. So I'll continue. Resilience is the capacity of the ecosystem to respond to perturbations by resisting damage and then recover. So that would be homeostasis. I think if I turn, I get the feedback. So this represents in the bottom panel, and so this is just this is not pH or anything. This is just a representation of change. The green is the homeostasis. This is the healthy condition. If you apply some kind of challenge here, then you may get a temporary dip into a challenged zone, but normal homeostatic mechanisms should allow return to health. It was represented here. But if for some reason, and that's represented by these adaptive processes that are tailored towards the need, both intensity as well as direction, but if people are at risk for whatever reason, then their response to the same challenge may put them into a disease or at-risk zone. So you may get either a longer period of change from the healthy condition to the green condition, or a more prolonged drop into that. And that's when disease occurs. So the hypothesis here that is that supporting the mechanisms that confer that resilience are the most important things to help maintain oral health. And that's really more of a rounded definition, ecological definition of oral health. And we can apply this to disease, caries, periodontal disease. Obviously, I'll talk a little bit more about saliva and how that influences that process. So to summarize, oral diseases are, of course, multifactorial. they're a result of an imbalance in the oral ecology. So it's that imbalance shifting away from homeostasis that is the issue. A minor increase, you don't need many, it's a small increase in the number of plaque butane streptococci in the plaque itself could promote more acid formation, and there may be a certain amount of metabolic regulation goes on within those bacteria. But the key thing is major perturbation. These things, the disruptions, can occur as a result of, I would argue, a number of factors, but if we can just focus in on two. One would be increased sugar consumption, as I mentioned, so that's the snacking behaviors. So that could be in a healthy individual. But in another alternative to that would be decreased saliva flow. So people who have a challenged output of saliva for whatever reason would, of course, be at higher risk for developing disease as a result of this not having the ability to respond to the challenge itself. So in the oral cavity, of course, saliva is the major protective mechanism we have, and where it fits in here, so of course here's our classic Venn diagram of caries. Well, saliva influences all of these through its flow rate and pH, through its buffering capacity, through its composition. It's the fact that it's supersaturated with respect to hydroxyapatite, helps maintain mineral balance, helps maintain or promote remineralization when the pH is high. So all these factors, of course, as you well know, influence oral health. And I showed this diagram before, and so I won't go back through it, but as saliva plays this key role in maintaining the balance between demineralization and remineralization, and it's when you don't have saliva that you see these very profound effects. And in this case, a relatively young lady who had had radiation therapy for an oral cancer. Her teeth, I guarantee, she was left with canine to canine. Those teeth were in good shape when she started. The posterior teeth were extracted. She was given advice and fluoride. 5 years later, this was the result. So obviously, that's a graphic example. In most cases, we don't see things quite as profound as this, but we understand that saliva is the key driver for maintaining oral health, a key thing that helps provide that resilience to any kind of perturbation in the ecosystem. So we all know saliva has many, many functions. I've broken them down here very broadly into these three categories: digestion and taste, protection through washing clearance, buffer capacity, and then this other one is perhaps a little bit, we don't often see this one put in here, ecological modulation. Saliva is the medium that may initially promote the selective bacterial attachment to the tooth surface, the start of the biofilm formation. And in addition, saliva does function as an energy source, a carbon source of bacteria when you don't give them other food in the form of external carbohydrates such as foods and beverages. So multifunctional, and this diagram shows some of the functions of the different proteins of saliva as well. So many, many functions. If you lose saliva flow, of course, then you're going to lose all of those functions. So saliva can be stimulated. If you have the ability to generate some saliva, then one of the best mechanisms I know of for stimulating saliva is sugar-free gum. I used to collect saliva from subjects for research purposes, and what I found was we would use citric acid on the sides of the tongue, or we'd have people suck on candies, but certainly over time I found chewing gum gives the greatest promotion of saliva. The only difficulty with it, of course, if you're trying to collect pure saliva from the glands, it causes the devices to fall off the cheeks. So I look at it as there's a hierarchy of benefits. When you start to chew gum, the very first thing you see is an increase in saliva flow. So this is very simple. This is work that Dr. Colin Dodds had done a number of years ago, but it just graphically shows the effect. So saliva flow rate is around about 0.3 to 0.4 mils unstimulated condition. Once you start chewing, so you stimulate saliva, this red pinkish line represents the flow rate upon stimulation. Very rapid increase. So due to the combination of mastication and sensory stimulation through the gustatory effects of the sweeteners and the flavors, then you see an increase of flow rate, basically a 10 to 12-fold increase. So very immediate increase up to about 6 mils per minute. And then after the next few minutes, what tends to happen, as any of you who chew gum know, the flavor starts to go away. And so you get less flow rate, a little bit of adaptation here. So over a period of 20 minutes, 15 to 20 minutes, the flow rate has tended to go down. But even at this point, if you continue chewing for 2 hours, we have data that Dr. Dodds also collected on 2-hour chewing, that flow rate is maintained, and it's more than double the unstimulated flow rate. So you're just doing something there to help aid clearance of sugars and keep the mouth in a somewhat healthy condition by removing extrinsic sources of sugars for the plaque bacteria. The other line represents what happens if you take away the flavor. So that's just an unflavored chewing gum base. And this represents, of course, this is just the effect of mastication. Put something new in your mouth, and you start to simulate saliva just through mastication, the presence of something in the mouth. After this period of time, they're both about the same, simply because you've lost the flavor from the chewing gum. So the next benefit, if you like, in the hierarchy is fairly straightforward as well. That stimulation of flow helps aid sugar clearance from the oral cavity. And this is graphically represented here, and this is a study that was done on people who consumed a Oreo cookie. So, of course, that leaves a very visible evidence of food debris in the mouth and residual carbohydrate sitting there in our caries-prone occlusal surfaces. And you can see on the right side the measure after chewing gum for 2 minutes. So in as little as 2 minutes, quantitatively we can see here, this is an oral debris score. Immediately after consuming the cookie, we've got this high score. At 10 minutes, you've got, if you don't do anything, you still have about 20% of that original amount of carbohydrate remaining. So there are still sufficient sugars potentially there to be feeding the plaque bacteria to generate acid. Instead of just waiting for that period, if you just chew for 2 minutes, you see an immediate reduction down to about a little bit over 90% here, and at 10 minutes, we've virtually got 100% removal of all of that material, a combination of saliva flow and probably also the physical action of chewing helping remove it from the occlusal surfaces has helped remove a source of sugars that could be providing prolonged acid formation for the bacteria in the plaque for quite a long time. So following that, of course, the next benefit is a little bit more biochemical in nature, and it's really just not looking at the sugars, but looking at what's happening with the plaque pH. So on consumption of in this case, a sticky bread, the pH of the dental plaque will fall from somewhere around about neutral very rapidly, depending on where you measure it. In this case, 4.5, so this is an interdental measurement. This is from some work that was done back in the early 90s. And that pH is staying below a critical value, in this case defined as pH 5.5, for over an hour and a half, 100 minutes. But if you start chewing gum, basically as soon as you finish consuming the food itself, then almost immediately through the natural buffering effect of the bicarbonate in the saliva, you are neutralizing those acids. The acids may still be there, but the fact that you may haven't washed them away, but you've certainly neutralized them. So the combination of earlier removal, I should say, of the food itself that's causing the decrease in pH, and this neutralization is having a double effect. So this is the basis of claims that chewing sugar-free gum can neutralize plaque acidity. And then, of course, thinking about the ability for saliva to remineralize through its calcium and phosphate content, high pH conditions promote remineralization. So a number of studies. This is the earliest study that was done from the University of Liverpool back. It was published in 1989, so it's quite old now. But these studies typically use some kind of enamel, section of enamel from a human tooth that's mounted in a tooth on a human volunteer, and then over time these are demineralized and then worn in the mouth in some kind of appliance, as shown here, for periods, in this case for 3 weeks. This is a crossover study. And then measures of enamel mineral are taken. And this was done by transverse microradiography in this case, and you can see a difference in both the lesion area, the delta Z, this is the amount of mineral itself, and this is the depth of the lesion, and this is the percentage change. So if the subjects who chewed gum in this study showed a 28.9% improvement in the amount of enamel mineral. So basically, we'll say 29% remineralization occurred relative to what happened in a control group who did not chew. That was about 17%. So they did also remineralize, but the gum aided that remineralization process. And similarly, with respect to lesion depth, the depth of the lesion was reduced by 5.4% in the non-gum chewers. And I say non-gum chewers, these were the same subjects, they did a crossover, and by 9.6% when they chewed gum. So the basis of this is the high pH conditions help drive remineralization of previously demineralized lesions. So those are studies that were done using extracted teeth in volunteers wearing appliances. Here's a little bit more graphic picture. This is some work that was done from Professor Hu Diyu's group in Chengdu using polarized light. They were looking at young children. These were initially 8 to 9-year-old children identified with early or certainly non-cavitated, but certainly visible lesions, caries lesions on these labial surfaces of these incisor teeth. And you can certainly see the white spots here on this QLF image, quantitative light fluorescence. You can actually see much better the shadowing here, and over here there is some superimposed imaging that represents a little bit more of the quantitative value. So these kids were put on a chewing gum regimen for 4 weeks, and then 8 weeks they followed these. And of course, this is a nice picture showing an N of 1, but it does show quite clearly, if you look particularly at this middle image, you can see the reduction in the size of these lesions in as little as 4 weeks, and here going down at 8 weeks. And this superimposed image, you can also see that it's quantitatively is less. And of course, this is just an N of 1, but if we look at the values, you can see those changes in lesion area. This is the area, this is the intensity of the fluorescence. Little or no change for the no-gum group, but certainly with chewing either 3 or 5 times a day, you can see very substantial changes, reductions in the area of the lesion, and changes in the fluorescence intensity, indicating those lesions are stabilizing and remineralizing. So I like that study because it's real world. These are kids, these are teeth that would have otherwise decayed. So it really shows, I think it's the sort of latest generation, if you like, of the remineralization studies that were done using those appliances. So finally, thinking about the highest level of the hierarchy of benefits, of course, if you promote remineralization in that way, ultimately you would extrapolate that there should be a reduction in dental caries. So here I've summarized about a dozen, I think there are 11 studies here that have been done over the years, prospective clinical trials, typically in children, that have been done on chewing gum, chewing sugar-free gum, and showing caries incidence over periods of 2+ years. So I won't go through every single one of those. They go back as far as 1973. The most recent were published in China from 2004 and 2013. And two I've highlighted, for Bieswanger and Schurke, were studies that Wrigley, our company, had sponsored back in the 1990s. So all of those consistently show, obviously very different populations, but certainly consistently show reductions of caries incidence, sort of ballpark between 30 to 50%, obviously some higher than others depending on the subject population. So in overall, the median reduction shown in these studies is about 52%. And there have been some systematic and evidence-based reviews that support this. So certainly there is very strong evidence that sugar-free gum is helping reduce caries incidence through the mechanisms I've already talked you through. So given that, we've got some fairly new data that I'd like to talk about for a couple of minutes here on what could be the advantages in terms of government health expenditure if you're postulating that there's a decrease in caries incidence in kids. What does that mean to healthcare providers? What does that mean to the economy? So here is a study that was published early this year in the British Dental Journal. And what the authors did was that this was in conjunction with York Health Economic Consortium, and it was a study that we sponsored. This was published, as I said, in February of this year. They took one particular study that I showed before. This was a study from Lithuania, and they calculated they basically calculated the amount of caries risk reduction based on sticks chewed per year, and they took two approaches. One was a linear, just basically assuming that the reduction in caries risk relates linearly to the number of times you chew, and one was a little bit more conservative approach of saying, well, we really don't know. There may be a threshold that we don't know what happens at low frequency of consumption over the year. So they come together here, but it's a more exponential system. So they applied both sets of data, and they identified three potential scenarios of chewing gum. One was at chewing simply 2 times a day. The other was taking an existing usage pattern and just adding 1 more time a day. And the last one would be what we call the clinically proven 3 times per day. And they calculated based on NHS figures, they calculated the potential cost savings, in this case just for the 12-year-olds. Because the data that they were using were based on 12-year-olds, they only felt justified in applying this to 12-year-olds. And looking at the models, the exponential model, of course, is a little bit more conservative. So simply chewing 2 times a day would result in a potential cost savings of 1.1 million. These are UK pounds, 1.1 million. And if the linear, the less conservative, was confirmed, it would be 3.3 million. And of course, up to the final level of chewing, the clinically, quote-unquote, recommended 3 times per day, you get around about, at that point, because these two have converged, these two curves have converged, about the same. So potentially an £8 million savings to the UK National Health Service just based on implementation of chewing gum. So those were UK figures, and right now we've applied this to a much broader study. So typically, we were concerned that everybody says, well, what happens? You've got these data that apply to a population in Europe or the United States. What happens in my country? So we've been more recently working, and this is currently unpublished data, but we've been working with the Institute of Empirical Health Economics in Germany. And they have done very similar. They took available data from 25 countries representing the G20 and more. This was 50% of the world population. So 52.7% of the world population is represented in this data. And they took a very similar approach, that they identified the cost savings, that they worked with their health economists. They gathered data on treatment costs from all the countries. They had data on per capita consumption of chewing gum, so they actually knew what people were chewing. And then they applied a similar sort of regression formula to those data. And they, again, envisioned three different scenarios, slightly different, but I'll walk through them. The first is simply a standard usage level of 2 pieces of gum per week. And by the way, I should say that this was using the exponential conservative approach to calculating the dose response. The second scenario is just taking existing consumption and just increasing it by 1 piece per day, and then similarly to the last one, chewing 3 times a day. So the cost savings are actually, it's going to depend very much on 2 things. One is the prevalence of decay in the country, and the other one is the cost of treatment for that decay. So on a global basis, and let's just look at scenario 2, simply because I think it's probably more realistic. If you had people chewing 3 times a day, I think that's a massive increase in normal consumption patterns. But if you look at the global savings, cost savings for people, and this is the 25 countries, chewing an additional 1 piece of gum per day, $4.1 billion US. And on a countrywide basis, if you break it down, the United States would be represented $2 billion, which is actually very high. Why is that so high? Because the cost of treatment in the United States is very high. Countries like India and Indonesia had very low savings, more I would say, the order of $500,000 US under this same scenario. But I took specific data because I think it's obviously highly relevant to us here in Taiwan. So the savings, those cost savings to the people of, or the government, where you have a government-provided healthcare system, is $40 million US. So I think that's something that's certainly very excited about, having this data. We will be submitting it for publication. We have a report right now, and we're just kind of compiling this. So there's a huge amount of information on a countrywide basis. So we certainly think that we've provided perhaps an incentive for governments to look at it a little bit differently. We understand that fluoride, of course, is a very cost-effective way of preventing dental caries. We also understand that there are other ways of doing this. Chewing sugar-free gum is not the only solution, but it certainly is a contributor to overall reductions in decay levels and cost savings to government, and of course the attendant comorbidities that go along with dental decay. So I would like to just cover off a little bit of information that I often get asked about, which is, well, what about xylitol? What about what's going on with gum? A lot of, it really isn't rocket science when we talk about sugar-free gum. All you're doing is stimulating saliva, and everything, the saliva is the thing that has the effect. But there is certainly some interest in is there a magic bullet? Could you put something into the gum that does it better? And so obviously there's a lot of interest in alternative sweetening products, and I would say that the polyols we use, I've come up with 3 examples. Sorbitol, which is the most common polyol, is a 6-carbon polyol sugar, so it's got this, you can see the multiple hydroxyl groups that give it its name. Here is xylitol, which is a 5-carbon polyol, and here's another one which is a little bit less well known, which is erythritol, a 4-carbon. In general terms, they're a little bit less sweet. They're both sweeteners. They're less sweet than sucrose. Xylitol is about the same sweetness, but they're all very similar. They're either not metabolized at all, or they're metabolized very slowly by oral bacteria, so they don't have an effect on the dental plaque pH, and they're found to be non-carcinogenic in animal studies. So the question was, is one better than another? And certainly there's been a lot of focus over the years on the sweetener xylitol. And I put this, this represents, it's people talk about it coming from the bark of birch trees. I have to say that xylitol is actually, as we buy it now, as we see it, is synthetic. It's generated, it's synthesized through enzymatic processes. It actually has a high carbon footprint, so it's not quite as natural as you may be led to believe. There's a higher carbon footprint than other polyols. But it doesn't kill bacteria, but it's not metabolizable by those bacteria. It doesn't support the growth of in vitro. It certainly doesn't seem to support biofilm formation, and is known to accumulate as a non-metabolizable intermediary in strep mutans cells. But there's a lot of perception that xylitol is somehow superior, and certainly as as I go to meetings, I hear this a lot. Well, what about xylitol? And so I did a sort of a quick straw poll of studies, and when I looked at the actual clinical data where systematically there's been a comparison of a chewing gum, these are chewing gum studies, of a xylitol-containing chewing gum or a gum sweetened primarily with xylitol versus one sweetened with another polyol, predominantly sorbitol, I found very, very mixed results. So I certainly won't walk you through these, but here are a series of studies. These are 8 studies that looked at, as an endpoint, some kind of plaque measure, typically plaque pH, in some case remineralization or mutant streptococci counts. So 4 showed a positive effect, 4 showed no difference. So, you know, there's our 50-50 in this case. So looking at these studies through 2009, I'm still not convinced. I mean, certainly at 50-50, it's not convincing, and there aren't too many organizations that have actually said that xylitol is better than other polyols in this sense. Secondly, looking at there's a limited number of clinical caries studies that have been done, so I was able to identify 4 studies, and again, 50-50. So the first 2 studies did not show a difference between xylitol-sweetened products and the other products. In the first case, whether you had low or high xylitol, the result was about the same in terms of caries increments, and then the 2 studies below that suggested that from Mäkinen, one of the Finnish researchers, has suggested that xylitol worked better, significantly better than the other alternative polyol sweeteners. So we sort of net out with a 50-50. So I would go back to my premise, which maybe there's a small effect of the polyol, but certainly in general it seems like it's mostly the act of chewing generating saliva. But of course, you know, we continue to be interested. So here is the one I mentioned before, erythritol. Erythritol is a less well-known polyol sugar. It's actually not as sweet as xylitol, but what's interesting is it is non-caloric and it has no laxation effects compared to the other polyols. So 30 grams of sorbitol or xylitol can give you some digestive upset, but in this case, erythritol does have none of those. So Mäkinen, who I mentioned earlier, did a study back about 10 years ago that suggested that actually based on both the in vitro, so some in vitro data using typical dental microorganisms, had similar effects to xylitol, and he also, as part of that study, provided chewable tablets in a clinical study, and again, it seemed like the 3 were about the same in terms of their effect on plaque. But more recently, there was a clinical study that was conducted in Estonia, and it was published in 2012 by Honkala, that showed this was a 3-year clinical study that was conducted on 1st and 2nd grade children. They consumed lozenges sweetened with either erythritol, xylitol, or sorbitol 3 times a day, and the intake was calculated to be around about 7 grams for each one of those. And I don't have all the data here, I'm not presenting all that, but certainly of interest was that in this case, erythritol seemed to do better than xylitol and sorbitol. So xylitol didn't come off better in this study at all, and certainly it's something that it's probably worth watching the space to see if erythritol gets more development in products in the future as a result of this kind of information. So I think I've led you through a lot of studies. We talked about the primary benefits of sugar-free gum through the established benefits that we know of stimulation of saliva, the removal and clearance of carbohydrates, the neutralizing effect on the plaque pH, the promotion of remineralization and reduction of caries. I talked about ecology. I think it's something that is of interest, and how much more subtle effects, and whether we can show an influence on the ecology through that, and how chewing gum may be working through promotion of saliva generation and therefore enhancing this homeostasis. And finally, talked about these health economic benefits. So having done all that, I hope I've convinced you that we have some real benefits and that sugar-free gum does belong in the preventive armamentarium, along with topical fluorides, oral hygiene, systemic fluorides, all the other things. It's an adjunct, another tool in the toolbox, if you like, to help reduce decay in our patients. Thanks for your attention.
Thank you, Dr. Okay, thank you, Dr. Dodds. 现在是我们 Q&A 时间. Now it's our time for Q&A. The first question is, what are the contraindications for sugar-free gum? 就是好这些 sugar-free gum 有没有什么 contraindication?
Thank you for the question. I think that's certainly very pertinent, and I would say, I'm not sort of contraindication, but indications, the ability of the patient to be able to chew and swallow normally. So very young children, I think I would say would be contraindication. I don't have a hard age range for that, but I think school age is probably a good time to start. Other contraindications would be a hypersensitivity to certain sweetening agents, and we call that phenylketonuria, which is a metabolic concern that people are not able to metabolize the aspartame, which is used in sugar-free gum. Another contraindication, I think, would really be if somebody doesn't have the functioning dentition to be able to chew, if they have very mobile teeth, then I think that would be another contraindication. I would also, despite the fact I've never seen convincing evidence, I would say if a patient has a history and has been diagnosed with temporomandibular joint dysfunction, then they probably wouldn't recommend them to chew excessively. Those are the only contraindications that I'm personally aware of.
Okay. Dr. Dodds, we have one more question that is from the line group, which was asking about sugar-free gum. If it actually increased the pH, could it actually be a substitute for mechanical cleaning like brushing?
So the question, as I understand, is would sugar-free gum, by raising the pH, be a substitute for brushing? No. I would never propose it be considered a substitute in any way. It's always been an adjunct. Good oral hygiene is the primary focus of our prevention, and we're just providing an opportunity for on-the-go oral hygiene when you don't have the opportunity to brush, and you can return the plaque pH neutrality more rapidly.
Thank you.
Professor Dodds has...
Yeah.
I think there's very convincing evidence now in the literature about the efficacy of chewing and chewing gum. And, you know, I don't think there is really much doubt if you look at a lot of the systematic reviews. That is very, very convincing that it has a real beneficial effect on oral health.
There's one more question in terms of other xylitol-containing products other than chewing gums. Are they effective? Can we use xylitol sugar, which was available, and then using that, put it in children's drinking water, or use homemade popsicle, things like that, as an alternative to, say, chewing gum, xylitol chewing gum, which younger kids could not chew?
I mean, certainly there's evidence that xylitol lozenges, and I think through the same mechanism of action, through this saliva stimulation, can have an effect. I talked about latterly the study that was done on erythritol lozenges. There were erythritol, xylitol, and sorbitol lozenges in that study, and they showed reductions in caries for all three of those. So I see it as an alternative. But I would also say that the evidence isn't as strong, and in general terms, the amount of salivation you're going to get from a lozenge is relatively less than it would be from chewing the gum.
Thank you, Doctor. Now we're going to turn to Dr. Dougal's questions. We have compiled quite a long list of questions from the online list. So the first question is about whole technique. So the question is there any study that has longer than 2 years with the whole technique, and what are the criteria?
Yeah, at the moment, the results, I think there is a 36-month trial already published in I'm trying to remember which journal, but there is definitely data for 36 months, and there will be longer-term studies as well, because there are 2 major trials underway. And when we get the trials, the results from our fiction trial, which is going to be the largest clinical trial ever done in the world on this topic, I think that will almost certainly answer the question. Because the problem is, you see, at the moment, a lot of the clinical trials have been done by the Dundee group, which actually makes sort of, they are the ones who publicize this technique. So sometimes, these days in scientific research, this question of conflict of interest comes in. Whereas a fiction trial is a completely independent study funded by the National Institute of Health. And it's a 5-center clinical trial done in primary care. So I think once we get the results from that, it will settle the debate once and for all. The criteria, which is going to the second question, are usually freedom from pain and sepsis. So if a child does not have freedom, does not have pain or infection, then that is considered as a success. I mean, what else do we need as success? It's just freedom from pain and sepsis.
Well, then the second question is, for whole technique that's using on like second primary molars, since we're choosing the bigger crown sizes, does it actually has a potential to impinge the eruption of?
Yes, very good question. I mean, almost certainly that would be the case if your crown is excessively large. But the way you do the whole technique is that you try, when you choose a crown, don't seat it fully, because you haven't given local anesthetic. If you seat it fully, you can't then take it off without hurting the child. So you just try it on the tooth, and you should get the feeling that if you just push it, it will seat with a snap. And then you fill it with the cement and you put it on. Because you've already created the space by putting the separators in. So, yes, you're right, it should not be excessively large distally, because then it could impede the eruption of the first permanent molar. Having said that, the 3 trials that have been published so far have actually not pointed that out as one of the problems in the whole technique.
Okay. Well, we just got one more question. One question that recently we just got. So if we're using the whole technique on adjacent to, say, D and E together, how do we actually clinically perform that? And then if there is the opposing dentation also are SSC without the reduction, will the vertical height become so high that the children cannot tolerate?
Yes, I mean, in my opinion, that can be a problem. But you always do it. You don't ever do the same side together, because then the bite, you can put the bite too much out of sync. I would do it on the opposing sides. So if you do the lower left, you can do the upper right, and then the upper left and the lower right. You can do two stainless steel crowns in the same quadrant, but the way I would do it is I would put the separator in, put a crown on one, then put the separator in again, and do the crown on the other one.
So you wouldn't do it on the same day?
Unless you have enough space to seat 2 crowns, which is those of us who regularly do crowns on D and E together, even with the conventional method, we know that it's not always straightforward to get 2 crowns in on the teeth. So with the whole technique, that is a little bit more tricky. So I would do one, then put separators in, and do the other at 2 separate visits. Pardon? I usually prefer to do E first. Yeah. Yeah.
Okay. So now we also have some question with the MIH molars. The first question really is, if we're taking this one molar that we deem need extraction, do we actually extract the contralateral side, because it will actually cause a midline deviation?
There is no evidence that extraction of first permanent molars unilaterally causes a shift in the midline. In fact, all the evidence related to shift in the midline relates to upper first primary molars. So if you extract first permanent molars, you should not get any shift in the midline. The only thing is, if you're taking the lower first permanent molar out on one side, usually it is better to take the upper one as well. Otherwise, you get over-eruption of the upper permanent molar. So you would usually take first permanent molars on the same side, if you're not doing all four, of course. But there is no need to balance for first permanent molars. There is no evidence of midline shift with first permanent molars at all.
Right. There's one more question is about the extent of the affected enamel that we took out in MIH in affected molars. So exactly at what level do we take out if we're doing a restoration?
If you're doing a composite restoration, then of course you need to finish your composite on sound enamel. If your enamel is hypomineralized, you can't finish your composite on it. So as a guide, just remove the enamel till you think that what you are leaving behind is sound. As far as the discolored dentine is concerned, or discolored enamel or dentine, these days we don't consider discoloration per se as an indication of active caries. And as you know, there is this big concept now floating around in dentistry, in restorative dentistry, on affected dentine versus infected dentine. If you think a dentine is discolored, but it's not infected, then you can leave it behind, because you can never, once you have hypomineralization or a carious process, dentine will get discolored, but that's not an indication of being more aggressive. So I would very happily leave behind discolored tooth surface, as long as I can be convinced as a clinician that there is no active disease in that part.
Thank you, Doc. Just one question for Dr. Dodds about the xylitol, which is, what is your opinion about how much % of xylitol in gum is ideal for prevention? Like, what's the ideal percentage of xylitol that we use?
I'm not sure there is an ideal percentage. I mean, based on the evidence I was proposing, xylitol is maybe considered a nice to have in there, but again, just reviewing the studies, there doesn't seem to be anything consistent that says you need a certain amount of xylitol to do this. I mean, the xylitol proponents have suggested that a dose of somewhere between 6 and 10 grams per day is required to have an effect. To deliver that in chewing gum, you're talking about 100% xylitol and consuming probably 5 or 6 times per day. So it's very difficult to deliver 6 grams of xylitol from chewing gum. So if you're looking for that effect, I'm afraid you won't see it.
All right. Dr. Dodds, I'm sorry. There's one more question just popping right up. In terms of the preschool children's, what are some of the xylitol's products that you would recommend the preschool children to use instead of chewing gums?
I am sorry, I have to defer because I'm not aware of specific products. The only thing that I have heard of, and I'm not personally familiar with it, are xylitol wipes that I know have been workers under John Featherstone in the University of California, San Francisco have used, but I'm not personally familiar with them.
So one more question is, in terms of with regard to xylitol, is besides the oral benefit, does it actually have other benefits, for non-infection, preventing infections in other part of the systems in the bodies?
So there have been studies that suggested a decrease in middle ear infections in children who consume xylitol in some form or other. Those have been reviewed, and one of the organizations that's done this is the European Food Safety Authority, and they've not consistently been found to be convincing. So I'm not aware of other specific health effects. And as ever, I would defer to my card-carrying cardiology pediatric dentist colleague here to see if he knows anything beyond that.
Well, thank you, Doctor. So we'll go back to Dr. Lucas. So there's one question with him. One of the audience have a question in terms of the pictures that it was presented earlier with the demarcation of the MIH molars. So on the right side of the screen, which is the easier one to find the demarcation, but then on the left side seems to be a little difficult. Could you actually give us a little more explanation on that?
Yeah, I mean, on the right-hand side where you put yes, that's actually not a demarcation. That is a post-eruptive breakdown of enamel. Right. Demarcation actually is, I don't know if you have my presentation still on screen. I can show you very, demarcation is very, very clear. If you look at any tooth with MIH, which has, so you can see in these pictures here that you have, even when you see a tooth which looks pretty hopeless, so let me see again, here. So when you look at a hypomineralized molar, which you think, oh my God, it's completely affected, just look very carefully, put a light on it, look at it with a mirror, you will always see a delineation between the normal enamel and the affected enamel. That is actually one of the prerequisites to call that tooth as a part of an MIH spectrum. Otherwise, it isn't. Demarcation is always there. Even though when you first look at it, you think, oh no, everything's affected. But look carefully, you will see it. And I have almost never seen a tooth, hypomineralized tooth, which is a part of the MIH spectrum, which does not have a clear demarcation. So here, for example, even when you look at this one, it looks pretty hopeless. But look on the buccal side, you will see a demarcation with the permanent teeth, with the sound enamel. I thought I had another slide here somewhere which showed it very, very clearly. But let me do, no, obviously. Oh, here, look at this one. See, this is clear demarcation. This is sound enamel, and there's a demarcation with the affected enamel. If you don't see a demarcation, usually it's something else. Demarcation is a very important aspect of the MIH spectrum, but you always see it. And if you look at the studies that were done in New Zealand, very nice studies, and the reason I'm very familiar with these studies is because the Erin Mahoney, who did the studies in New Zealand, I was actually the external examiner for a PhD. And there were fantastic studies, and she showed very clearly that if you look at section teeth with hypomineralization, which are a part of MIH, whatever is affected is affected. But just a few microns away from the demarcation, the enamel is absolutely normal. Which is why I kept saying in my talk that this suggests some sort of a chronology in the etiological event because of this demarcation.
Thank you, Doctor. There's one more question for Dr. Dodds, and then we will take a break. Any question afterwards, we'll try to squeeze out another Q&A session in the afternoons. So the question is, any concern about the increasing tooth wear during the chewing gum frequency, and how long should the chewing gum frequency be to reach the effect?
Let me start with the latter. So how the question is how many times, you mean frequency of consumption?
Consumptions.
And
correct.
so I go back to the best frequency is the one that's clinically proven, which has been 3 times per day. That's the idealized scenario. Of course, people don't chew 3 times a day, but that would be the optimum. So if you're applying it to somebody who's a history of caries, then I would suggest that you would look for 3 times a day, typically after meals. In terms of tooth wear, I've never seen anything to suggest that there's increased tooth wear from chewing gum. We did studies a number of years ago that were based on looking at some abrasive components in chewing gum, because you can put, there are a certain amount of mineral in there that can be perceived as a filler, and they did they took impressions of the teeth and looked for microscopic scratches as a result of the filler materials, and there was no evidence of that either. So I've never seen or heard of excessive tooth wear as being a sequelae of chewing causing tooth occlusal reduction.
Thank you, both of speakers.
Okay, just one. Then I need to choose the most difficult one. No, I'm just kidding. Monty, you mentioned because the caries, the disease is in the biofilm. So you said, we need to manage the ecology. And I think your approach is really impressive, because you approach from a human side. It's not only, and Michael's approach is homeostasis. You want to change the biofilm. But Monty, you didn't say much about how to manage the ecology.
Yeah.
And also, but when we talk about the biofilm, there's a homeostasis and also homeostasis, which means if it's a healthy biofilm, the shift to what we call a keratic biofilm, it becomes stable. Both way, the healthy film is stable, and the disease film is stable, because from our perspective, we say, disease film is not stable. No, but from the biological point of view, for the bacteria, this is the status I want to keep. So in that sense, what's the way we should manage the ecology?
Can I start with this one? Yeah. There is a very important concept, which I think, Mike, you picked up in your presentation. In the past, people were coming up with all sorts of medications where people said, in children with caries, you can put iodine on their teeth to kill the bacteria. You can put so-and-so medication. So people were coming up with all sorts of things to kill bacteria. The whole concept now has gone away from killing bacteria to actually homeostasis and moving the biofilm towards health rather than disease. So what we don't want to do is we don't want to kill the bacteria. We just want to shift the ecology of the mouth towards health. And that is a really important concept which has come in the last few years. And and I mentioned a few things on what I meant by ecology, shift in ecology. And I think what Mike's presentation also sort of contributes to is that chewing gum, again, is not delivering anything lethal in your mouth. All it is doing is shifting the biofilm towards health, away from disease. And I think that's where that concept of, allostasis and resilience comes in, that it would be very easy to add a lethal substance in the chewing gum to kill the bacteria. But the whole concept these days has gone away from bactericidal to shift in ecology. And that's why all these things like chewing gum and what we are using these days, it's all focused towards balancing the ecology rather than killing anything and putting something else in.
Thank you. We are really run out of time. Oh. I'm sorry.
I was just going to say I totally agree, and I think the focus is really as much on manage the environment. You manage the environment with behavior change, dietary change, and another aspect of that, in a case of raising the pH, would be through gum, but it's really managing that environment so that then the ecology will follow as you do that.
Thank you.